IAP as a President-elect Central IAP 2024. Yeah, so this is really neurology is my one side of my heart, and you can say one side is the ID chapter and one side. But I think neurology overpowered me not only because of a subject, but people. कारवा बनते गया, मिलते गए, लोग मिलते गए, but really as a great people I got. I was never knowing who is a Praveen, but I got Praveen, Sharma madam, like this. See, it's very difficult to have a search the people in Delhi like Delhi, Mumbai, like the metro cities, because छोटे गांव में तो लोग मिल जाते हैं, but to recognize all the people from metro, it's very difficult. That I could do in a neurology chapter. I could open the 7 to 8 chapters. Not only that, fellowship also. The fellowship number was only 2, and that we made 9 fellowship. Even Kashmir, like a state where we could do the not only conference attended by 700, but also 2 fellowships are going on there, and we are getting very good fellows from Kashmir. So really, that's my gain. I always feel happy and blessed that I got so many friends through neurology chapter. And then when you go into any subject, then thoroughly you get engulfed in it, and that's why it might be the things I at least 50% of the knowledge I got in a neurology also, that which is really needed for every person. And this project of a postgraduate clinic in pediatric by Sir Gangaram Hospital and IAP New Delhi, really there is a great conjoint activity. I know Gangaram is the second name of academics only. Not only the where the patient get treated, but I think in private sector the only hospital where academic it overpowers everything. So like people like Dr. Sajdewa and all these people are there. So that's a great thing. And once again, congratulations to Alok Dhankar sir, that Delhi IAP, that doing really great project. And my request you, Alok sir and Dhankar, that please go for the project, help that project like IAP के बाद community के साथ. Tomorrow there will be a Down syndrome day, and so we are releasing some lectures on the material for Down syndrome. Please disseminate this lecture, take some public lectures, or it should go to public. What is the Down syndrome? What is the treatment, and how we can help the mother father for that? I know it's a very difficult task, but if every pediatrician think that we have to go ahead and disseminate the knowledge about those Down syndrome or some all these pictures, so you can do it. Nothing is difficult. So I wish once again best for this postgraduate clinic in pediatrics by Sir Gangaram. Congratulations to all organizer and participant. Thank you, Dr. Praveen, Anita Madam, for your all these knowledge and you are sharing here. So thank you once again. I wish all the best.
Thank you, sir. Thanks.
I think Dr. Praveen, we can start with the case. Dr. Vasant has already expressed the feelings about the field of neurology. So I think we can start with the case.
Okay, ma'am. So with the permission of our chairpersons, Dr. Naresh, we'll start this case, and maybe we can have questions during the case presentation also, because that can become slightly interactive, and the other questions can be kept in the chat box, and as and when we see, we can answer on the part. So, Dr. Naresh, please start the case.
Okay, sir. Good evening, all the dear faculties and teacher present over here.
Put your slides on screen mode.
Sir, I have put the slide on screen.
Yeah.
Now.
Yes. Okay. I am presenting the case of neurology, a child with neuroregression. Sir, am I audible?
Yes.
Yes, yes.
I'm hearing.
History. Patient name S, age and sex 5-year male child, resident of Faridabad, informant being mother, who is reliable. Child presented with chief complaint of difficulty in writing and declining school performance for past 4 months, difficulty in speech for past 3 months, not able to retain urine and stool for past 2 months, abnormal paroxysmal body movement for past 2 months, and progressive difficulty in walking with frequent falls for past 1.5 months. Child was apparently well 4 months back when mother noticed that the child had started having difficulty in writing when he was not able to write what was asked to him, and child was able to read the given text. Gradually, he lost the ability of reading as well over next 1 month. Complaint progressed to difficulty in recalling the names of family members, along with decreased interaction with others and surroundings, followed by lost in interest in eating food. History of difficulty in speech for past 3 months, which was initially noted by mother to have decreased in number of words he was speaking, along with decreased tone of sound, followed by some words in broken pieces. Currently, he is not able to speak a single word and mostly respond by making sound and gesture by pointing. History of urine and stool incontinence since last 2 months. Initially, child was able to appreciate the urge for urination, but could not retain the urine voluntarily. Currently, he was able to retain urine and stool and did not point out the wet pants. On 22nd December 23, child had abnormal body movements, which was generalized, involving all the 4 limbs, with tightening of limbs, uprolling of eyeballs, frothing from mouth, along with loss of consciousness, which was lasted for around 5 minutes. Similar 4 episodes noted in past 2 months of duration. He then started having episode of head drops, followed by jerky movement involving all the limbs. These movements were exaggerated by anger and excitement and subsiding during sleep. It was not sound or photostimulant. Child was fully conscious during these jerky movements. It was followed by complaint of difficulty in walking. Child was initially which was initially noted by mother to have reduced activity and frequent falls while walking. Child decline. This complaint decline over time as unsteady gait, followed by inability to stand and sit without support. The child is able to lie on bed and able to roll over, but unable to get up independently from bed, but able to lift up neck with some difficulty. The child is able to turn head sideways, able to reach for object, but unable to hold firmly a pen or tumbler when offered. For past 8 days, child was bedridden. The child was able to move the limb actively and there was no association of pain or swelling anywhere in the limb. There was no history of tone abnormality as noted by mother, such as increased tone while bathing. No history of floppiness noted while handling the child. No history of abnormal posture or contractures. No history of tremor on reaching for objects. There was no history of vision disturbances, no history of abnormal movement of...
Go back. So you have a kind of like given the chief complaints on the partner. This is quite a long kind of like chief complaints on the part. Now you're going to the negative history. Fine.
Negative history.
Yeah,
Yes,
because there are number of I mean the chief complaints. So just before you go for the negative history, just go the previous slide. Just tell us again, remind us again, what was the chief complaint by which the child has come to you?
Yeah, sir, chief complaint of difficulty in writing and declining school performance for past 4 months.
Okay.
Difficulty in speech for 3 months. Not able to retain urine and stool for past 2 months. Abnormal paroxysmal body movement for past 2 months, and progressive difficulty in walking with frequent fall for past 1.5 months.
Okay. So now these are the 5 chief complaints you have on the part. So based
Yes.
on these chief 5 complaints, what all thing which comes to your mind before you start asking for the negative history on the part?
So, sir, first one is, sir, child is
We
gradually.
ask for the negative history. You already have got something in your mind which you want to elicit and which you want to clarify, confirm with your negative history. Correct?
Yes, sir. So the significant first thing come to mind is declining milestone which were previously child has achieved, and gradually he is declining his school performance, difficulty in speech, not able to retain urine and stool. So gradually he is losing his milestone gradually. Also, child has episode of abnormal paroxysmal body movement seizure since past 2 months, and having involuntary movement, jerky movement like myoclonus.
Okay.
So the this child is having a neuroregression over the time.
Okay. So you're dealing with a child who has got neuroregression, correct? Number one thing. And only based on the history, can you tell me from which part of the brain it can be originating from brain and the neurospinal axis, so that you
So
can look at those parts? Yeah.
yes, sir.
Anatomically?
Sir, most significant area involved is cerebrum, from where the cerebral cortex, from where the this declining the regression.
Yes. Why
And
not? So yeah, please complete your words. Yeah.
yeah, that's also.
Okay, so two things: which areas in the cerebral cortex, based only on the history, and second thing, why not a spinal cord also getting involved? Because you mentioned about retention of urine and stool also, na?
Sir, child has complaint of not able to retain the urine, and which was appeared after 1 or 2 months of previously declining school performance, difficulty in speech, followed by urine not able to retain the urine. So it is not any acute condition or traumatic spinal injury or something.
So you mean to say that it could be possibly because of his cerebral involvement only that he can't hold the urine, correct?
Yes, sir, possibly. Uh,
And then which part of the cerebrum, the gray matter and the white matter? I'm trying to make it slightly simpler for the postgraduate students, for them also to understand that which part of the now cerebral cortex, the gray matter or the white matter, which seems to be involved based on the history.
Sir, cognitive and uh, uh, cognitive function, and that indicate the gray matter involvement.
Okay.
And sir, this seizure part, that seem to be uh, that is also a gray matter area.
Good.
And sir,
You're having mild cold and cough, Naresh. Fine, na?
yes, sir.
You take care. And the second part you said about the progressive difficulty in walking, and that involves
White matter, sir.
possibly you're not sure because you have to look for the signs of white matter on the partner, but
Yes.
because when you are cognitively declined from the gay matter, you can always have the kind of like gait problem also from there, or maybe from the cerebellum also on the part. Okay.
Yes.
So this is the area which you are looking for. So now that is the one thing. Now go back to your you continue with the case, but all negative things you want to evaluate in this child.
Sir, because child was not cooperative, and he was very irritable, so I had tried to ask maximum question to mother and parents, so that I can get some relevant history.
Okay. Fine. So please proceed.
Yes, sir. There was no history of vision disturbance, no history of abnormal movement of eyes, conjugate deviation of eyes, no history of deviation of jaw while eating, no history of deviation of angle of mouth, able to close eyes while asleep. Sir, this is the history to rule out the cranial nerve involvement. No history of hearing disturbance, no history of exaggerated response to sound, no history of deviation of tongue. He was able to turn the neck and head sideways. No history of pulling of secretion or difficulty in swallowing and regurgitation of food.
Yes, go back again on the part. Go back
Yes.
again. So apart from indications of your cranial nerve dysfunction in these cases, what can all else you can find in a child with neurodegeneration where you look for the history of vision disturbances?
Sir, because neuroregression part involves retinal atrophy and optic atrophy and retinal pigmentation.
Okay.
So it was important to ask about vision disturbances.
Can you just give an example also here? Although we'll be discussing those things later on also, but that thing should be there in your mind once you're starting this case.
Sir, for optic atrophy, we can think of NCL
Okay.
and
What about the abnormal movements of eyes, conjugate deviation of eyes? Where do you find to be involved?
um, if there is a nystagmus cerebellar involvement,
Okay.
so we can get the conjugate deviation, and
You get the abnormal movement, nystagmus you get. Then
and
what happens to the eyes in cases of Gaucher's disorder, Gaucher's disease, or Niemann-Pick?
so there will be dysmorphic.
We're talking about the eyes. Okay, so you can have the horizontal loss of movement in terms of the pursuit and those ones. Fine. So when you're looking at the cranial nerves also, you can look for the thing which you already have in your mind, because you already said that you are looking at a child with the neurodegradation. Fine. So you have got all those things which can cause neurodegradation part, including the neurometabolic one. So all these signs which are sitting, or the history you are getting, that should be that should have something to say about your etiologies also. Okay. Proceed.
Sir, etiological negative history. There was no history of fever, loose motion, vomiting, ear discharge, or skin rashes. No history of headache or projectile vomiting. No history of dog bite or recent vaccination. No history of abdominal distension or icterus. No history of abnormal pigmentation of skin, any skin or hair changes.
We'll keep on telling, why did you ask for this history of abnormal pigmentation of his skin or hair changes?
Sir, the first one, history of fever, loose motion, vomiting, is to rule out the infection cause or inflammatory cause. No history of headache and projectile vomiting to rule out
What kind of fever will last for almost around 3 months? Because this is a very long history na, on the partner.
Yes, sir. Sir, if in case of initially there was a febrile illness and followed by like in post-infective encephalopathy.
Autoimmune kind of thing you are suspecting.
Yes, sir.
And maybe kind of like, because this is a very prolonged history, we're looking with the fever partner, so this could be something like a post-infective conditions, or maybe the conditions where you get the rheumatological conditions, the connective disorders conditions kind of thing, where you can have the fever and along with that you get the systemic signs and the neurological signs. Okay.
Yeah.
What about the abnormal pigmentation of skin and any skin or hair changes?
Hair, sir, abnormal pigmentation in adrenoleukodystrophy and B12 deficiency.
Okay, that's good.
And hair changes for sir Menkes kinky disease or.
And that is because of which this one, the mineral Menkes kinkage is because of
Sir,
the copper.
Copper, yes, sir.
Okay.
And no history of significant reduced head size or increased head size or any abnormal facies, and no history of abnormal odor of urine.
Okay. So which condition do you get where you start having reduction in the head size?
Sir, microcephaly, like Rett syndrome.
Yeah, but they won't have the regression in the head. We're talking about something which is the significant reduced head size, na?
Yes, sir.
So they will fail to grow and then they will stagnate now. So you don't get condition where you start losing your head size on the partner.
Yes, sir.
The increasing head size, increasing head size.
That to look for hydrocephalus and any intracranial space occupying lesion, tumors.
So these things won't cause. How old this child is?
Child is 5 year old, sir.
Okay, so you don't get at 5 years of the age when the sutures are closed, the AF is closed, the tumors, the hydrocephalus, causing increased head size, no?
Yes, sir. Before 2 years.
Yeah. So then
Increase ICP.
this will not cause the increased head size at this part, no?
Yes.
Leukodystrophies, the white matter one basically. The white matter one causes the increased head size. The gray matter one causes the microcephaly part.
Yep.
To start with, but this will not have the reduction on the part. Okay. And why about abnormal faces?
Dysmorphic features in case of any genetic or
Okay. And more than genetic?
storage metabolic
Storage
disease.
disorders, the MPS kind of things, basically, the mucopolysaccharidosis kind of, because they are more common to have the abnormal faces, no? The coarse faces you should get in cases of MPS part. Okay. So all these things should be having should be on your tip. Why did you ask for these kinds of histories? Okay. And why recent vaccination?
So vaccination is related to polio.
Polio causes the focal loss of power. So not the kind of like total neurodegradation. Na? Again, the post-infective one, the autoimmune part you suspected on the partner, which can get. Fine. Okay. I think Anita ma'am is also here. If she had the questions, huh? Okay then. Huh.
Past history. History of
1 second. I
Okay,
just you
so
mentioned the
Sorry.
hair and skin condition.
Yeah.
We should also remember biotin, because that is one which is treatable also, and combination of hair and the skin lesion, alopecia, and the skin rash, they are important, and you can have, because this is a treatable condition.
Yes, ma'am.
That's important. Thanks, ma'am.
Past history. History of measles infection at the age of 1 year was present. There was a history of fever episode 1 month prior to present illness, which was subsided by oral paracetamol after 2 days. There was no history of any drug intake or no history of trauma.
Which drug you suspect in this case?
Sir?
Which drug you asked for? Which drug you suspect, or you had any drug in the mind? Causing neurodegradation? Number of times, if child is someone getting basically anti-seizure medications, right? So they can have, people have got with the carbamazepine, the phenytoin causing the cerebellar atrophy and then regression on the part, right? So which drug can cause on the part? Okay. So trauma lead to neuroregression or not?
Not trauma, but sir, post-traumatic.
There should not be a progressive neurodegeneration in cases of trauma, because that becomes an static insult. Na? So you lose your milestones before the trauma, but it should not be declining with the trauma part. So they are not typical neurodegeneration. Na?
Okay, sir.
Where you got a progressive decline of your milestones, like in this child.
Static.
Yeah, so once you have the trauma, you lose the milestones and then you remain on that part. Okay.
Family history. Single child born to non-consanguineous parents. There was no similar history in the family, and mother has CNS tuberculosis 5 years back. Further treatment was taken. There is no significant history in the family related to present illness. Antenatal history.
What can be family history significant? Which kind
Yes,
of
sir.
like?
Family history is significant, sir.
Which kind of family history can be significant, like?
Sir, in case of genetic disease, family history is important. Example is like Lephora body disease. That if sibling or any person in the family is positive for Lephora body, which is a PME, then again child can be a Lephora positive.
So you need to look for the disorders where you have got the similar kind of history on the partner. The
Yes.
neurodegeneration one, the neurometabolic one can be there. Or maybe at times the history of tuberculosis also, if they're running in the family, not many years back on the part.
Yes.
Okay.
Antenatal history. There was no significant antenatal history. Mother age at marriage 20 year. At the age of conception is 22 year. Primary mother was booked and on regular follow-up. IAP tablet taken. Injection TD was taken. Yes, sir.
Okay.
Natal history, child was term delivery, born by a normal vaginal delivery of 2.8 kg, cried immediately after birth. There was no nursery admission and no history of neonatal jaundice. Smooth neonatal transition, baby was handed to mother and breastfed within 1 hour. Developmental history, child has achieved all the developmental milestone up to the age of 5 years before the illness, and then he lose the milestone. Current status is motor, walk with support and sit with support. DA is 7 to 8 months and DQ is 13%. Speech and language able to produce sound, reciprocal babbling, and not able to speak a single word. Developmental age is 7 to 8 months and DQ is 13%. Social and adaptive skill recognize mother, not able to feed on self and unable to indicate need for micturition or defecation. Again, developmental age is 6 to 7 months and DQ is 12%.
What is reciprocal babbling?
Child look at the action or behavior of.
Okay, so you should be prompt with the answers. Anyway, move further.
Immunization history. Child was immunized till age of 5 years according to UIP schedule, and BCG scar was present. Socio-economic history. Family comes under the upper middle class according to modified Kupuswamy scale.
Could you see the vaccination card also?
Sir, there was no vaccination card available with parents.
So how can you write about according to the UIP schedule?
Some mother was saying she has given all the vaccine to government vaccine center up to 5 years, and she was strongly convinced.
Okay. So I think it's wise to mention here that you could not see the vaccination if they can provide, because you have got history of measles you mentioned in the past now.
1 year of age.
Child with the regression, yeah, child with the regression on the part, and this is very pertinent from the history.
Yes, sir.
And yeah, what is the upper middle class now? So that's something where that becomes yeah.
Class, the Kupuswamy scale is based on income, education, and family income, education, and working.
Okay, so I'm just saying that because it's an upper middle class kind of family, no? So this will be preserving the vaccination card also, because that is required in the school admissions and those things also.
So, she has a vaccination card at home, but she was not bringing it with.
Okay.
Nutritional history. Child was exclusive breastfed till 6 months. After that, complementary feeding was started, and breastfeeding was continued till 1.5 years. Calorie and protein adequate and there was no deficit of calorie or protein.
Okay.
Summary. This 5-year-old male child born of non-consanguineous marriage who was a developmentally normal child with normal neonatal period, immunized up to age with no significant family history, with normal nutrition and belonged to upper middle class according to modified Kupuswamy scale, was apparently normal till 4 months, now brought with suggestive history of decline in milestone intellect for past 4 months, speech difficulty for past 3 months, bowel and bladder incontinence for past 2 months, generalized tonic-clonic seizure for myoclonic jerks and ataxia, with past history of measles at 1 year of age. This is a case probably of neuroregression. Differential are like SSP, PME, progressive myoclonic epilepsy, chronic heavy metal poisoning, although there was no history, but lower down it could be. These are the differentials.
Okay. Unlikely to be the heavy metal poisoning. Now, which place they belong to?
Sir, there is a industrial area, but like a pencil factory, could not confirm.
And second thing is that which chronic metal poisoning we're talking about in this case?
So lead poisoning could be
Okay.
lead and capital.
Naresh, they will be anemic also. So your physical examination should, here also you can mention without organomegaly also, because you are writing about it, and anemia is a significant finding if it is a lead poisoning, if you think of so. So that is again an important negative point. And I think you should have one thing, as a presenting as a case, as an examination or as a student, I think you should have not said that this child is completely immunized. That is, a trick in exam also. You should be, smart in answering the question in examination. You should not have said that the child is immunized, because that point, if you say that it is not there, it supports you. No, Dr. Parveen?
Especially when you don't have seen the immunization card on the partner. So because
Yes. Examination smartness is, not saying that it is completely immunized. I don't think.
or you can make a point that
So,
you have not seen the card, so you're not sure of the part.
yeah, don't mention it. Don't say it.
Okay, ma'am.
Okay, so you talked about the SSPE. You talked about the second is you say about the progressive myoclonic epilepsy, and okay, and the late poisoning, which looks unlikely. So how do you proceed now, Naresh, for investigating this case?
So for investigation, we can go with
Before investigations, can you tell in brief what are the points against this Friedreich's ataxia in this case?
Sir, Friedreich ataxia, there is skeletal deformity will be there. That is not in in our child.
Which kind of skeletal deformity?
Sir, kyphoscoliosis will be there.
It requires some time to develop. Then,
sir, intelligence will be normal in Friedreich ataxia.
And maybe the seizures part.
Yes, sir.
What about Wilson's?
Wilson's, sir, also in case of neurogenic Wilson's will take long time. Age of presentation is little, and more of Wilson is like, sir, more of extra pyramidal activity and movements like involuntary movements, and
Seizures are less likely in the part.
yes, sir.
What about, you talked about what is the ALD?
Sir, ALD is adrenoleukodystrophy.
How do they present? What is?
Sir, age is like 6 to 50, 6 to.
Okay, and how do they present? Adrenoleukodystrophy.
So there will be sign and symptom of adrenal insufficiency, like pigmentation of skin, and
that takes time to develop. But how do they present?
Sir, they present with generalized tonic-clonic seizure and
Likely because with leukodystrophy, na, you just said, na, कि white matter disorder.
yes, sir.
Matter one. Vision disturbances, gait disturbances, spasticity, starting from the posterior part of the brain. So vision disturbances first, where they can't see, they can't read, and then the leukodystrophy part, the white matter signs in terms of the gait and the spasticity part. Okay. So
Naresh, what is the inheritance for ALD?
Sir, ma'am, ALD is one is X-link.
Yeah, so that your child is also male?
Male child, yes, ma'am.
Yes.
Infantile is X-link.
Okay, so then how do you proceed to distinguish this as an SSPE? Because now you told that based on the clinical and the examination part only, you could differentiate. This doesn't look like to be Friedrichs or Wilson's or the maybe the ALD component also. Okay, so now how do you differentiate or how do you investigate further to say this is SSPE versus all these PME? What all you investigated? Proceed.
In one point I can just add, if it is okay.
Sir, please. Yeah, please, sir. Please.
Can it be some other bone and post-encephalitic sequelae? Because the child had fever also in the initial onset, you never know post-encephalitic sequelae other than the SSP. Post-viral encephalitis sequelae.
Sir, because there was no sign of meningitis, neck stiffness, or so infective part was, and fever was just 1 or 2 days, which was subsided, and there was no any irritability or headache, vomiting. No,
because post-encephalitic also can have neuroregression, and this can also, other than the SSP, any virus infection in the past causing encephalitis can cause sequelae. Is it okay, Dr. Parveen?
So there are two things, sir. Maybe we are discussing it slightly further from the part. So one thing like post-infective, we talk about the autoimmune processes, the autoimmune encephalitis processes, where you can have the regression and multiple sign and symptom which is coming up in the subsequent months. So that is the one thing. Second thing that if you're having a kind of like chronic virus infections, like how the HIV kind of part, where you can have the progressive neurodegeneration because the virus still is there, or the kind of like what we get in the Creutzfeldt-Jakob disease, the CJ dub, what we used to be like cow mass, the disease. So those can have the prion kind of things in those kinds of the part.
Okay.
Okay, there is the next. How do you investigate?
Sir, first
part. Yeah. So proceed fast. What are the positive findings in this?
Sir, there was child was lying supine and bedridden. He was irritable, and anthropometry normal findings, sir.
Go back on the first slide. You said he was conscious, alert, but not irritable.
Sir, but irritable.
Okay. Irritable, not irritable. Irritable. Okay.
Irritable.
Fine.
Anthropometry normal, growth was normal, sir. Height is within 50th centile, 18.3 kg weight, 18.2 kg weight in expected to 18.3, and height is 97th centile, and BMI is 3rd centile, which is low according to age. Head to toe examination, there was no pallor, clubbing, cyanosis, or lymphadenopathy. Head appear normal in shape, hair normal, no facial dysmorphism, eyes, ear normal, oral cavity, skin, and no neurocutaneous marker, skin is normal, no chest deformities, BCG scar was there, limbs, there was no bony deformity or edema, or no clubbing in fingers. Systemic examination, nervous system, higher function, handedness was right-handed, child was awake, not interested in surroundings, irritability present, recognized mother, interact by gesture and sounds, speech, child was aphasic, if he has aphasia, no emotional disturbances, no sleep disturbances.
When you talk about this, just go back on this slide. Now, when you say conscious, so consciousness means that you should have all the three components with you, Naresh. The awake, the alert, and the aware, the triple A. Fine.
Yes.
So like I said, he was awake, he was alert, but he may not be aware. So he may not be fully conscious. Okay, so you should be mindful when you would conscious in these kinds of children because they are slightly encephalopathic, because they are not aware. Right now, you are just mentioning that he was not interested in surroundings and he was quite irritable.
Yes, sir.
Refrain from using the word conscious over here. Just say in the sentence.
Yeah. Sir, child was semi-conscious.
Nothing like semi-conscious partner. So you can just put in the word like how you put it over here now. That's correct. This is correct on the part.
Yes, sir.
Okay.
Cranial nerve examination. Sir, child was not so cooperative, so we have done. I have done some of the cranial nerve examination, and rest was not examined. Sir, cranial nerve 1, 2. Cranial nerve 2, bilateral pupils equal and reactive to light. Fundus was done by ophthalmologist, which was normal. Sir, I cannot see the fundus. And cranial nerve 3, 4, and 6, no squint nystagmus, no ptosis. Cranial nerve 5, sensation present over face, able to chew the food, no deviation of jaw.
How did you make
Cranial
about sensation present over the face?
Sir, expression of child's.
But that's very crude now.
Yes, sir.
Because you don't know, because the moment you touch the child, whether he's making a face because of his apprehension, you approaching him with the eyes, or he might be having some kind of auditory myoclonus on the partner. Unless until he says to you about all these sensations, you can't totally say he has really felt your sensation and they are equal on both right and the left side. So sensation requires his cooperation now.
Yes, sir.
It's why not to use it when you can't be sure on the part.
Sir.
Okay. Fine then. Next.
Motor system, bulk was normal on both right and left side. Mid-arm, forearm, mid-thigh and calf. All the both the sides symmetric. Bulk was symmetric and normal in and tone.
Slightly difficult to take because as you mentioned the child was irritable, 5-year-old child, irritable 5-year-old child who is normal, cooperative. As a pediatrician, this is not easy to take their mid-arm, mid-forearm, mid-thigh and mid-calf kind of like bulk, and that 20 centimeters partner. So if you can't do it, it's why not to say, especially if he's an irritable child.
Sir, I have tried, but it was difficult.
As a pediatrician, it's difficult. The
Yes.
examiner also know this is difficult in a irritable child, na?
Yes, sir.
Tone.
Sir, tone was slightly decreased on all the limbs.
How do you explain decreased tone when you have got a kind of like your DD as a SSP first and second you kept as a PME, na?
Sir, because child was in position, all the limbs in flex position, and upper limb, knee, hip, ankle, they are in flex position. So it was mild hypotonic.
Okay, so what I mean to ask was that normally when you see a child with the SSP, as you had the first differential, what kind of tone should you expect in these cases?
So in case of stage 2, 3, it will be increased tone.
So maybe he's in the stage 1 itself.
Stage 2, sir, child was in stage 2.
Okay.
Again, sir, power was not performed.
Okay.
And reflex is not done, sir.
You write about the extensor plantar, na? The extensor.
Extensor was plantar were extensor, sir. Plantar did.
Okay.
Deep tendon reflex again not done. Other systems, sir, all the system, abdomen, RS and CVS, all are normal.
Again on the part, but DTJ you can do now. The child, even if he's uncooperative, you can do the deep tendon jerks. Why this is important? The deep tendon jerks in these cases. Because looking for signs of leukodystrophy, white matter signs, whether you're finding hyperreflexia in these cases or not. That gives you a sign. You're looking for cerebellar signs, pendular jerks in the part. So you have to spend some time in the DTR. You can leave the sensory with not cooperative, but DTR will be important to look for because that will divide this is in cerebral, this is in cerebellar, or this is in a spinal kind of thing versus all those kinds of like your dip down the level, the Friedreich's ataxia and those ones where you get the features of neuropathy, the absent reflexes. Okay. Nothing in the other examination part, na?
No, sir.
What is important? What is important in the abdominal system? Ma'am also asked.
Sir, if there is a hepatomegaly or any organomegaly, hepat or spleen, that is important.
Anything in the CVS from neuroregression?
CVS, sir, if valvular disease or
more than valvular? Valvular doesn't have any neurodegeneration kind of thing, no? Or what kind of valvular if you're talking about the part? More of a cardiomyopathies, which can be there with a lot of conditions, no? The neurometabolic ones, fine. The Friedreich's ataxia one, the mitochondrial ones on the part, features of cardiomyopathies. Okay.
And sir, summary, this is a 5-year-old male child born of non-consanguinity who was a developmentally normal child with normal neonatal period, immunized and with no significant family history, with normal nutrition, belonged to upper middle class, was apparently normal 4 months back, now brought with a history suggestive of decline in milestone and intellect for 4 months, speech difficulty for past 3 months, bowel and bladder for past 2 months, GTCS seizure, myoclonic jerks, ataxia with past history of measles at 1 year of age. There was no history of vision or hearing loss and no organomegaly, no other systemic involvement. So,
one thing I would like to add, complete the CNS findings completely. You should mention the signs of meningeal irritation, whether they are present or not. Then you always described, you said abnormal movements are there, so you have to exclude the cerebral sign, as Dr. Praveen said. It should be a part of complete examination. You see the components of CNS examination, you have missed the signs of meningeal irritation, which should be mentioned, and abnormal movements you have to describe whether this is because of cerebellar. So cerebral signs has to be explained. Whether they are present, child is cooperative or not, you have to mention it.
Yes,
yes, sir. Investigation part, CSF fluid examination, no inflammatory cell or definitive organism. MTB was not detected. Cell 2 counts per microliter. Coagulum absent. Normal appearance. Glucose was 59 milligram per dl. Protein 30 milligram per dl. Chloride 126. LDH 15 international unit per liter. Fundoscopy was done, which was normal. Blood measles IgG was positive, 6.51. CSF anti-measles antibody was sent.
Any significance of blood measles IgG antibody?
Sir, it could be due to vaccine or infection. So IgG.
Infection means the past infection.
Yes, sir, past infection. And increasing titers in CSF is important, sir.
Okay. So you have sent the CSF anti-measles antibody. Which antibody is IgG or IgM?
IgM, sir.
Why IgM? What does it mean by IgM and IgG?
Sir, IgM is a recent infection and IgG is remote infection. So,
are you suspecting recent infection in this case, measles encephalitis, or suspecting something in the
no,
past?
sorry, past, because it was at 1 year of age.
So you'll be sending for which IgM or IgG?
IgG, sir.
Okay.
EEG was done, sir, and it shows polyspike spike and wave pattern with slowing background activity with regular intervals.
Okay. That's interesting. So can you tell something about, although this is not your domain at your level, what do you find in this EEG, the niche, the down one? That's beautifully placed.
Sir, this is a typical radar maker complexes, which are sharp and slow wave pattern of 0.5 to 3 second, which occurs repeatedly at every 4 to 16 seconds, and they are polyphasic and high voltage spikes and waves with slowing background activities.
What you're finding is the kind of like periodic complexes. So after a couple of seconds, you're finding the burst of discharges. These. Na?
Yes, sir.
That could be a feature of your SSP on the part. Okay. They got different features.
This was MRI done on initially 2 months back, sir.
Okay. Anything in the MRI?
Sir, MRI.
The first is the MRI or the first is the CT?
Sir, first one was this one is CT.
Yes.
And this one is MRI.
Yes, so you've got both the things now.
Yes, sir.
Okay. And what do you expect in these things? If you're suspecting about the SSP or those ones, the PME, do you suspect anything?
Sir, cortical atrophy.
Cerebral atrophy, and then signs of leukodystrophy, isn't it? Subacute sclerosing. Sclerosing is a white matter disorder.
Yes, sir.
Okay. Then?
Sir, these are the investigation which are significant
On the part. So how do you confirm now?
Sir, after CSF measles antibody and progress of clinical.
Couple of things. What are the other things? What are the other PMEs which you have mentioned? The progressive myoclonic epilepsy. What are the progressive myoclonic epilepsies? Name 3 or 4.
Sir, ULD, NCL, MRF, and Lafora body disease. MRF is mitochondrial myoclonic epilepsy with ragged red fiber syndrome. And
what happens in those? That is the mitochondrial disorders. What happens in that? Characteristic feature of MRF is?
Sir, accumulation of ragged red fiber in the muscles and
clinically.
Clinically, sir, myoclonus is a prominent feature, and ataxia might be there, along with generalized tonic-clonic seizures. And,
features of mitochondrial dysfunction, the failure to thrive, the hypotonia, the poor growth on the part. Okay. And what happens in the NCL, the neuronal ceroid lipofuscinosis?
Sir, NCL also present with same myoclonus and
what happens to vision in NCL?
Sir, vision and hearing will be lost.
Important thing.
Yes, sir.
Okay. So how do you manage any medicines you can? I mean, if the child comes positive for the your CSF measles antibodies on the part, how do you manage them?
Sir, we can give interferon alpha, isoprinosine, intrathecal interferon alpha, and inoprinosine. And sir,
isoprinosine is oral, IV, or intrathecal?
Sir, that is IV, and intrathecal is interferon alpha.
So isoprinosine is oral tablets, na?
Yes, sir.
Okay.
And
which other drugs?
Others, sir, to control seizure, we can give myoclonus and seizure, valporine, topiramate, lamotrigine, phenobarbital, and we
What is the
should.
prognosis? What is the prognosis?
Sir, prognosis is very poor. 90 to 95% of children die within 2 or 3 years.
And if the mother
And
asked you that if my child was already vaccinated with the measles, then how did he get this measles related kind of like encephalitis? What will be the answer? So you need to ask part also, no?
yes, sir. I have to confirm the vaccination part, sir.
You have to read about the how did part. I think there's some questions also. Limb flexion is suggestive of hypotonia. Is it?
Sir, in case of less than 2 year or smaller children, when we cannot perform for the tone, we can see the posture of child, and if there is a decorticate or decerebrate flexion or extension.
So they may suggest, but they're not the absolute partner. So flexion
Yes,
can be there in cases of contractures also. No, they're contracted, so they will be flexed all the time, isn't it? So that can't be true for the hypotonia. It can be there in the hypertonia also. The second question by Dr. Bhatnagar is, what was the basis for the diagnosis of measles in the child? Could it be just a viral exanthem other than measles? Very correct. I think we cannot lay a lot of stress on the diagnosis of measles at age 1 year unless it was confirmed by a pediatrician. Very correct on the part, no? Okay.
yes,
Because at 1 year you get so many viral illnesses which can manifest on the part. So anaphylaxis have been seen, documented, especially in a child, as ma'am also mentioned, who has been vaccinated on the part. No? There comes the role of the part, but they really had the measles at 1 year of the age on the part. I mean, the forum is open for the questions. Anita ma'am, something from there. I think Dr. Basantar has left. He had some work.
He has left. Go ahead, Dr. Parveen.
Naresh has discussed it quite nicely, and it's important that we should be, thinking of infections as one of the cause. But one of the thing is that with vaccination, it is not reported. It is either the vaccine has failed.
मैम आप
और
इतने
then-
ऑडिबल नहीं है, थोड़ा सा माइक को ऑन करके पास आ जाइए. You're not
Mike,
that audible.
right now you can hear me?
मैम अभी भी आवाज क्लियर नहीं है मैम.
Okay.
I can hear, yeah.
You can hear. With vaccine, it is not reported because there are some literature studies where the where it has been reported that after the vaccine, the SSP has happened. There are reports where they have, done the biopsy of the brain, and the virus which was isolated was the wild virus. It was not the vaccine virus. So almost nil case has been reported with we can say that it doesn't happen with the measles vaccine. Maybe when the measles vaccine had been given and the child gets measles, maybe because the vaccine was not potent, or the take up of the vaccine didn't happen. But it doesn't happen. It has not been reported in the literature with the vaccine. The reports show that it is the wild virus which has been isolated from the brain biopsies. So I think we should stress on the vaccine. And because you asked me, you had a very relevant question that the mother may say कि वो लगाया था फिर कैसे हो गया. So that answer should be very clear. We should be promoting the vaccine.
True. On the part, any questions from our postgraduates? I mean, we have a lot of panelists also. Comments from the panelists. Lalit sir, I think I can see Dr. Prashant sir also over here on the part.
Dr. Praveen, we don't find so much so common nowadays. It is 1 into 1.2 million, I think, what we used to know about SSP. That it is still existing. I think long back we used to see, and gradually over the years, the incidence has gone down. How commonly you see nowadays SSP?
True, sir. I think you're right. It's not very common, but I will say there has been some amount of resurgence of SSPE in almost past 5 to 6 years. And in our experience, what we saw that maybe 3 4 years back we had a kind of like fulminant SSPE, where we get a child in a month of, and we get a child and within a month they used to have a kind of like very severe deterioration. So this was there almost around 3 4 years back. We had almost around 4 5 cases in a single year of fulminant SSP, and that has been described also. Then during the COVID, we didn't have those ones, but now again, almost a year. I mean, I'll just tell you, a month back only, I had a child referred to me from the orthopedician colleague of mine only, because the child went to them first. He had fell down from a jamun tree, and then he was not walking well. So the parents felt that this is an orthopedic problem. By the time he was seen by orthopedician, he did the investigation, he was okay. Then he was sent to me. He was sitting in my OPD, and I could find him that sitting, and he was having this head drop. Head drop. The diagnosis was there only, and I could count that every 10 seconds he had this head drop. So it's very classical of the SSP kind of thing now, that you can count in the OPD also, that they've got very periodic kind of like epileptic seizures. So every 8, 10, or maybe 14 seconds, they will have a kind of like head jerk. So we got the EEG, and this is suggestive of the periodic complexes. So although uncommon, definitely uncommon, but that becomes a good diagnosis to exclude, because then you don't go for all those kinds of difficult tests or kind of like costly tests to exclude the progressive myoclonic epilepsy, because that bunch is quite costly. When you go to the PME, like look at this child also, this child had come, and clinically also we could exclude this is not a PME. All these progressive myoclonic epilepsy, which Naresh also mentioned, the Lafora bodies or the NCL or the Unwirtz-Lundborg disease, the sialidosis, so they will have the clinical features also. Like some of them can have features in the eyes. This is very important thing. Ophthalmic evaluation, you find cherry red spot, you find features of retinitis pigmentosa. When you do the EEG, you find a very significant photosensitivity, photic stimulation kind of discharges, which happens with the Laforas and those ones in a part. So clinically also you can exclude a lot of these disorders, the PME kind of thing where they require enzyme assays or whole genome sequencing on the part. So clinically, SSP becomes a clinical thing to diagnose and then to
and are there any other viruses associated also with this kind of a presentation with neuroregression?
We had, I mean, I mentioned to you, I mean, I had a child with the HIV encephalopathy, the child who came with the neurodegradation part, and he has been worked up extensively. And by the time he landed to me, he was having this kind of like typical neurodegradation, but he had the features of MRI abnormalities in the periventricular area. And not at the first glance we could think of HIV, because we don't think HIV as a kind of like first diagnosis in the pediatric age group. But because he had the neurodegradation part and the MRI was suggestive, so we sent the investigations, including for the HIV part. He had history of liver abscess and tuberculosis in the past to, I mean, help us. But HIV is one thing. At times, we have seen couple of cases of JC virus, especially in children who have been treated with the kind of like leukemias, managed with the kind of like anti-leukemic medications, and then they have got it, the JC virus kind of thing, the regression on the part. At times, the medications like rituximab, which you use for a number of conditions, cancer, non-cancerous, so they can also cause the progressive multifocal leukoencephalopathies kind of presentation. So drugs also in the correct context.
And post-Japanese encephalitis can also present with neuroregression over the years. What is your experience?
I mean, so these all the post encephalitis will have a kind of like sequelae. So maybe like they will be having the encephalitis part. So they will deteriorate, and then they will be at that level, or they will be improving slightly on the part. So they should not have a kind of like typical regression. So like they are losing their milestones one by one in the subsequent months on the part. So they will be having the features of
static.
static. Yeah. So
Dr. Praveen, even I've had a patient of ITP, chronic ITP, who was treated with rituximab, and then somebody added cyclosporin also, which also is known to cause this kind of a problem. And he developed the slow virus leukodystrophy kind of a thing. And in addition, can I request Dr. Srinivasan, who's a very senior pediatrician Pondicherry, to please comment on the case? He is still there.
Yeah, thank you. But I think it has been discussed well, and of course, this child that usually the presentation of SSP is a deterioration of regression of milestones, then frequent falls, and then seizures. But anyhow, it has been very well discussed, so there is nothing for me to contribute. Thank you, sir.
Thank you very much, sir. Thank you very much, sir.
Thank you, sir.
Dr. Praveen, you have really summarized and moderated very well. And what we gather from this, that SSP, of course, should be considered in the DD of every neurodegenerative disorder case we find. But one thing, with the vaccination coverage for measles increasing, almost in all over India, we have covered through MR vaccination campaigns. It has been covered very nicely. So the incidence of SSP, of course, should decrease. But even the vaccine is supposed to cause few cases of SSP. What about that?
So I think as Dr. Anita also mentioned about the part, so we still feel that it's not because of the vaccine virus per se causing the SSP. What they are describing is this before you give the vaccine. So there have been a lot of literature about this part, and we had a couple of cases with the proven SSP from very good families. So 4 years back, I had 2 cases with a very good families, with the SSP part. So that time we reviewed the literature and we found that it is because of the virus which has already affected the child before the child got the vaccination, maybe around 7 months or 8 months of the age per se, and the virus was lying there on the part in their as a kind of like dormant, and now it has culminated into the SSP kind of pathology on the part, the dormant virus over there. So still the literature say that this is because of the infections part per se, maybe because before the vaccination has been received by the child in a way, and later on because of the immune dysregulation, this is being manifested rather than because of the vaccines per se.
There are many neuropsychiatrists who are, discouraging patients from MMR vaccine, particularly in many neuropsychiatric disorders or developmental disorders like autism, etc. Few from your hospital as well, you may be aware. And I've seen some patients who have been particularly discouraged for MMR vaccination. What is your opinion about that?
Not at all, sir. I think we don't have any evidence today to discourage this vaccine for any neuro related illness. So in one sentence, we don't have any evidence to discourage it. In fact, we promote.
Can I answer that question, sir?
Yes.
Yeah. Actually, after that, a lot of studies have come in Lancet and British Medical Journal that it is not really proven and it's not associated. That's why, again, there is a increasing use of measles vaccine in United States, etc.
In fact, the article with the person who had, I'm forgetting the name of the person who had said that this MMR is related to the autism. He had withdrawn that article. It was in the Lancet. That article was withdrawn. It was a conflict interest. So this paper has been withdrawn. So that is not there.
No. And purple book clearly states no relation with any neurodegeneration with any vaccine, especially this.
Dr. Praveen, can you in 2 minutes give the salient features of the disease SSP? Because somebody is asking that question just as a take-home message.
Yeah, I only asked the same thing. Yes.
Suspect SSP in any child of any age. That's the one thing. We had child of 3 years of age also with the SSP part who comes to us with the progressive loss of his milestones, starting first from the cognition in terms of his behavior, intellect in a way, then having some loss of his motoric ability in terms of his walk in a way, and then having the jerks and the seizures part. So these all three things should be there. A child who starts with the loss of his cognition, intellect, if he's a school going child, then will complaints from the school like in this child, then he will having some amount of unsteady gait, and by the time he comes to you more often, he will be having definitely the jerks and the seizures part. That's the number one thing. When you go for the EEG, you ask for an EEG with two things: the photic stimulation, because photic stimulation with the hertz 1 to 30 hertz, because that can help you in excluding a number of progressive myoclonic epilepsy condition. And second thing that you asked, to get an EEG with the slow paper speed, where you can see the periodic complexes on the part. The third thing you need to know is the ophthalmic evaluation, where you ask especially for fundus, retina, and look for cherry red spot, because that can again exclude a number of these progressive myoclonic epilepsies. And fourth, you do the LP, and we send for the CSF and measles antibodies in the serum paired sample, and we get the results on the part. I think this is the in crux.
Well summarized.
And prognosis is very poor. Ultimately, how much is the survival?
I think they say from the textbook that there are 5% chances of a child coming out of the SSP part. Practically, we didn't have any. There are a lot of medications, alternative medications, the homeopathic part, that all is going on the part, but none of them have really worked, including along with the intrathecal one also. We have number of studies on that part also. So it has mostly a progressive decline.
And anything in relation to autoimmune disorders of the encephalitic, other things, they can also present in later on, or they only just recover in the acute phases. Right.
So you mean to say that the autoimmune encephalitis presenting like this?
Autoimmune disorders of this thing, like we are getting autoimmune encephalitis, we are giving the responses to the biologicals and steroids and other things we use.
So that's very pertinent question, sir. We always keep autoimmune encephalitis as a differential diagnosis whenever we get these kinds of presentation. That's the number one thing. Second thing that, but practically autoimmune encephalitis doesn't have so many months to come to us. So they will be kind of like yeah, so they'll be slightly more acute. I mean, in most of the cases, in a way, in the part like they have this, the SSP has got slightly delayed presentations. But definitely, when you do this when you do the CSF part, so you always keep the sample for sending it for the autoimmune antibody I mean, test also on the part in those cases.
Thank you.
Thank you. I think we are done with the part. There are a number of questions. CSF IgG is gold standard. So we have the CSF IgG along with the measles IgG. So we get the quotient ratio, and this is, so let me tell you, this is not really gold standard. We had two cases of false positive CSF IgG versus measles IgG antibodies also. So there can always be a false positive case also be on the part. So you have to see how the disease also progresses on the part. So they can be false positive also. Then second is, can you please shed some light on common causes of neuroregression in India? So I mean, definitely SSP and all those which we have discussed. I mean, we have discussed about, I mean, see, they can be the whole etiologies. You can have the autism as an autistic regression part. Then you can have the infections, as we mentioned about the encephalitis and the temporary neurodegeneration part, post-infectious like autoimmune encephalitis and those ones. SSP also becomes in those part. The neurometabolic ones, the NCL and those ones in a part, and the toxins ones. And yeah, so autoimmune encephalitis we discussed, definitely a possibility we need to exclude in these kinds of cases. We look at the EEG part also to distinguish this in autoimmune encephalitis versus an SSP. SSP has got a very classical EEG. So EEG helps us a lot in differentiating between the autoimmune encephalitis versus the SSP part, and even from the all your kind of like PMEs, the progressive myoclonic epilepsies. So good quality EEG helps you a lot in distinguishing SSP versus all these kinds of differential diseases on the parts. So They say this is, Dr. Sambi asked, incubation period is quite long. The child presented earlier than usually expected. So this is very pertinent. I mean, the textbook teaching initially was for 10 years. So we didn't used to think about SSP when I was a postgraduate student before a 10-year-old child in a part. But nowadays we know that because of, change in the whole of the epigenetics part, you can have SSP, at any age on the part, definitely on the part. So now that doesn't hold true about the incubation period and all those things. And
Parveen, Dr. Parveen,
yeah,
younger
ma'am.
the age, more the acute onset.
Yeah, ma'am has very, very rightly said about the part. So I think Dr. Sunil also had the similar kind of question. Can measles vaccine cause? We answered this part, and I think we answered all, ma'am. Anything else from the part?
I think we've done a brilliant job, Dr. Praveen, Dr. Anita, and Dr. Kalatkar, who's just left the meeting for another, meeting of the IAP. Can I request Dr. Dhankar to thank all the panelists and the students?
Right. Thank you very much, sir. Before I thank, I would request Dr. Sareen, sir, to say a few words. Sareen, sir. And Dr. Satish Sharma, sir, to say a few words before we close the session. Sir, am I audible?
Yeah.
Satish, sir, Sareen, sir. Right. So it's fine. Maybe they are occupied with something. So let me take this pleasure and honor to thank you all. Dr. Praveen, Dr. Prashant Seth, Lalit Mendiratta sir, Dr. Sareen, Dr. Srinivasan, and our presenter, Dr. Naresh, Dr. Neeta Sharma madam, who has been my teacher. And I was remembering that ma'am was holding me now, even that I'm not able to differentiate between rosary and scurvy rosary. So
I will tell you again, okay?
Ma'am, I would
but
love
you
to.
don't get so fulminant cases now.
Right. And Dr. Satish Sharma sir and Anupam Sachdeva sir, who is our mentor and host. So thank you all. It was pleasure. SSP is still prevalent, and we need to prevent it rather than, because there is hardly any therapy. As Dr. Parima was mentioning, clinically we do not really see any response from any of the therapies available with us these days. Thank you very much. Thank you.
Thank you and good night, sir.
Thank you. Good night.
Thanks a lot. Thanks, Naresh. You presented well. Thank you.
Good night, sir. Good
Thank
night.
you, sir.
Thank you, Dr.
Good night, Praveen sir. Good
Thanks,
night.
sir. Thanks.
Mukesh,
Pleasure meeting
good
you
night.
all.
Lalit Mendiratta sir. Good night.
Good night.
Srinivasan sir. Good
Well
night.
done, Dr. Praveen.
Good
Thank
night.
you.
Good night, Anupam sir. Good night.
Good night.
Sir.
Good night.
And regards and good night to Dr.
Good night, all of
Anupam
you.
Sachdev sir. Anupam Sachdev sir. Yes, sir.
Thank
Regards.
you very much. Thank you, Parveen.
Good night, ma'am. Yeah. Thanks, ma'am. Thanks for joining us.